Fantastic. Thank you. I'm really excited to be here at the Crohn's Colitis UK Virtual Patient Involvement in Research Day 2020. My name is Tom. I'm a medic by trade, and I'm also currently doing my PhD at the University of Oxford. So today we'll be speaking about really recent advances in how we understand health and disease at the most fundamental level of the human body, which is the cell. How we can translate these advances and apply these to solve one of the major unmet needs in IBD, mainly why medications do not work for all patients. And at the end, I'll leave with a thought piece on how can we implement this for the future and the trials of the future. So I'll actually start by talking about chemistry instead of biology. Dmitry Mendeleev was actually a giant in the world of chemistry, and in 1869 he came out with this periodic table of elements, which has really laid the foundation for chemistry since then. And it has allowed chemists worldwide to understand and predict general properties of elements, allowing for the discovery and characterization of these elements, and leading to allowing us to harness the elements to help advance technology in the 20th and the 21st centuries. So how can we get closer to the ground truth, the fundamental elements in biology today? Well, we've already started doing that since the early 2000s with the Human Genome Project, which really aimed to understand every gene in the human body. And we've done that with a great degree of success. And very recently, over the last 5 years, we've turned our attention to studying individual cells, really brought about by advances in microfluidics, being able to isolate individual cells. And of course, as we know, cells make tissue, tissues make organs, and of course, organs make organ systems until we get the whole human. And this mission essentially aims to create a catalog, a reference map for human cells, both in health and in disease. And this essentially allows us to discover and characterize individual cells in the human body. But how can we harness this? How can we harness this to benefit patients? Well, there are several challenges that lie in harnessing this understanding at a very single cell level for drug discovery. And applying this to inflammatory bowel disease, there are two key elements. One is that people are different. Genetics factors, for example, smoking habits, which are particularly pertinent to inflammatory bowel disease, and also dietary factors that can then influence the microbiota and so forth. And of course, we know that the inflammatory bowel disease, it's a very broad term, and even within diseases, there might be different habits. And so these factors really prevent not just single cell, but really any technology from being the holy grail of drug discovery. So we've set about sort of looking at it from a broad perspective. So there are a lot of things we don't know, but we do know that some medications do work for patients, even amidst all this differences across patients. And one of the really common factors is a drug called adalimumab, which I'm sure that many patients are familiar with. And this is really the first line biologic that patients, not only in inflammatory bowel disease, but also in rheumatoid arthritis, get placed on by the traditional sort of treatment algorithms right now. And the way that adalimumab works is still very much uncertain. We don't know exactly how adalimumab works at a very fundamental level. However, we know that it does provide benefit in approximately 6 out of 10 patients that we give this medication to, and it does not provide benefit in about 4 out of 10 patients. And we're still a long way from understanding why that is the case. TAURUS is really a project that looks at applying this new technology to really profile patients over a period of time. And to do this, we've really needed buy-in from patients, both in Oxford and in Birmingham. And this is a cross-disease study because we know that adalimumab does work across diseases. And essentially, the study design is a before and after study design, as we call it. Essentially, this is embedded within routine standard of care. These patients would have been placed on adalimumab anyway. We take biopsies during routine endoscopy before they go under treatment. Patients stay on the treatment for about 6 to 12 months, of course, always being governed by what is clinically appropriate for that at that period in time. And then we take samples after patients are on adalimumab. And that allows us to see how cells have changed following exposure to adalimumab. And each patient acts as their own comparison group. This allows us to a degree to control for these various degrees of heterogeneity and variable factors in each patient. In addition to this, we also see actually how have cells changed in the way they speak to each other before and after therapy. Of course, we want to establish what does a drug working mean from a patient perspective. So the other element of this is embedding a tool called Truecolours into the study. And Truecolours is essentially a questionnaire that gets sent out by the phone to patients who are consented. And that allows us to capture at a very granular level what impact has adalimumab had on patients' quality of life and also disease activity. And over time, over 6 to 12 months, that really enables us to understand at a very granular level, how has this drug impacted patient life? And is this providing benefit for patients? Is it working for patients? And how do we take this idea forward? And really, this would be amazing if we could do this as a roadmap for the future. It is really to take TAURUS forward, both for existing therapies, so adalimumab, vedolizumab, ustekinumab, but also for trials that are coming out and embedding it in randomized control trials and so forth, where we're testing new drugs and really aiming to understand that for every intervention, what exactly happens to patients when we give patients an individual drug, both at a single cell level and also at a quality of life level. I would like to acknowledge a massive team that has really enabled me to deliver this work, participating patients mainly, as without patients, this sort of technology and applying this sort of technology is quite impossible. And also my default supervisors, and also one of my notable collaborators, Charlotte, who's really helped me with the bioinformatics side of things, and funders to the left. Thank you very much.
Thank you very much, Tom. I know you've got a survey here, so I'm just going to launch the poll for you.
Fantastic.
Here you go. In the meantime, can you see the Q&A on your panel as well?
Molly Kenyon has asked, neither azathioprine or adalimumab worked for me, but vedolizumab worked immediately. Is this part of an emerging pattern? And thank you, Molly, for your question. I think generally this is a very difficult question to answer because, like I said initially, we are still struggling to understand exactly what pathway is working for which patient. And currently, there is a stepwise ladder that is at the center of guidelines. And really, that has worked well until now, given the understanding we have had. Moving to the future, the hope would be with single-cell genomics, we would be able to identify what drug would work for you. So you wouldn't necessarily have to go on azathioprine or adalimumab, and we would see with single-cell genomics actually vedolizumab would have worked for you. So that would be where we're trying to get to. The bridge there is, of course, that single-cell genomics is super expensive. However, there are clues from single-cell sequencing that we can take to histology, and therefore we can get understanding from single-cell genomics, transfer it to histology, and that can enable us to tailor therapy to you. Lucy has asked, will you be looking at side effects of the medication? So it's very difficult to tie in as single cell activity to a particular cell type, because we would have issues with powering that study. But we do keep we do try and seek understanding of actually what sort of side effects are patients developing, and that gets fed in through Truecolours. Julie has asked, why do these biologics suddenly stop working in some patients? And that's a good question. So biologics stop working for two reasons. So if biologics don't work within the first few months, and then there is clearly what we call primary non-response. However, we know that in patients that are on medications, sometimes patients develop antibodies, the body reacts against these medications, and also 10% of patients on adalimumab do lose that benefit of that medication every year. What are the long-term side effects of these drugs on the body? So that's also a very good question. So like everything in medicine, there is a benefit and risk ratio that we have to balance out, and this is best done with the patient involved. There are side effects to adalimumab. These are counseled to patients at the time of starting. So this includes melanoma, in some cases lymphomas, but again, these are in a very, very small minority of patients, and decisions need to be made in conjunction with the patient on what is acceptable to the patient. Alwyn Jarvis has asked, why do we not seem to have a way to tell via a blood test if Vido is working or not? So blood tests, so there's two ways of answering this. So one way would be, can we tell via blood test if Vido would work for a patient or not before the patient receives Vido? I think we're a fairly long way away from that, although there is some work going on with regards to looking at proteins within the blood to see if we could predict patients that are going on to Vido. To assess whether a drug is working or not, there's various modalities that we use. One would be blood tests with using CRP, for example, would give us an idea of the inflammatory processes that are going on. However, fecal calprotectin and looking via endoscopy and histology do still remain gold standards for looking at response to therapy. Sarah Williams has asked, adalimumab works well for my gut disease, but not so well for my vulval Crohn's, which still requires topical treatment. Could this study help understand why this might be the case? So essentially, the study is very focused on the gut. We haven't looked at extraintestinal manifestations of Crohn's disease, and so that wouldn't be within the scope of the study, unfortunately. I took adalimumab for 2.5 years and it worked really well. Question from Amanda Downing: my body then started rejecting it. Why would this happen? So there is interesting work going on to if patients are genetically predisposed to developing antibody responses to adalimumab, and we have tried to incorporate that into deciding what treatment patients should go on. For some patients, there is some evidence to suggest that adding azathioprine to adalimumab could prevent patients from developing antibodies. Hugo Blunt has asked, Humira works well to avoid acute symptoms for me, but not mild ones. How do you measure if a medicine is working or not? When do you consider that a medicine is working? That's a very, very tough question, and it's a pertinent question for this study because we have to look at when do we consider the medication has worked for a patient. So again, histology is a very good readout. So is endoscopy. And that is why having that before-after comparison is critical, because we can have a look with scoring systems, with endoscopy and with histology, and has there been some degree of improvement? That is one way to look at it. A second way to look at it is, has this patient needed help with steroids to relieve symptoms? And if we did, then does that mean that adalimumab is not working adequately? Then a more pragmatic approach is, has this patient needed to be switched to a different medication? And that would also be indicative of the drug not working. I am taking adalimumab for Crohn's. It has transformed my life. Great improvement. I've since developed an inflammatory arthritis. Might this be a side effect of taking adalimumab? So I'd have to defer to your practicing IBDologist for that answer, I'm afraid. This would require sort of an in-depth history and examination. Are you doing studies with infliximab yet? A question from Claire Marshall. So no. So initially, when we started the study, we did have a debate amongst ourselves whether we should put infliximab and adalimumab together and do a broad bucket of anti-TNF. And we decided to go with adalimumab because it's more commonly used. We're not thinking of doing a similar study with infliximab at this present time. Elsa has asked, have you tested other factors that influence the effectiveness of the drugs, such as taking turmeric? Not within the study, no. An anonymous attendee has asked, how do you support the body whilst on these drugs? Essentially, it's a balance, as I said before, for controlling the inflammatory bowel disease, as well as potential side effects. But if the side effects, again, this is done with the patient playing an active role in the decision making. If the patient feels that the side effects are impact life greater than that of the inflammatory bowel disease, then of course we will make the pragmatic decision to change medication. Amanda Downing has asked, adalimumab has always helped my flare-ups, but never helped the joint pain I suffer from since being diagnosed with Crohn's. Why may this happen? Amanda, this is one of those things that we're still struggling to understand, that we're still investigating. And there are some studies that are looking at applying the single cell approach to understanding whether there is some degree of cells, inflammatory cells, going from the gut to the joints or the other way around. But this is again an active area, an area of active research at this point in time. And Sarah's asked, if someone is on both azathioprine and adalimumab, then the azathioprine is withdrawn, how likely is it that the adalimumab will stop working? If the likelihood isn't well known, would this study help determine it? Although we do have patients with both azathioprine and adalimumab on the page in TAURUS, the study is not specifically set up to answer this question. However, the benefit of giving azathioprine in conjunction with adalimumab is to stop the body from reacting to the adalimumab and producing antibodies, as opposed to benefit directly from the azathioprine to controlling the disease. Zoomnik has asked, does ADA typically lose response after several years? So, like I mentioned, there are patients, approximately 10% of patients for whom adalimumab works do lose response, and we call that secondary loss of response. It's the quote-unquote term for it. So would we expect patients to typically lose? I wouldn't say typically would be the word that I'd associate with sort of 10% loss. Obviously, we'd want to understand this process of why drugs stop working, and that is why we set up TAURUS. Do you think biologics can be a lifelong treatment? I'm on my 11th year. Thank you for that question. I think the strategy has thus far been we use biologics to get disease under control, and then there is the extremely difficult decision to make to decide when should we stop therapy. And there are factors that do help us make that decision. For example, during endoscopy, if we look at histology and there is histological remission, and we know that those patients do fare better when we withdraw therapy. but again, this is a complex medical decision that's best made in conjunction with both the patient and the whole multidisciplinary team. I think that's addressed all the questions so far.
Fantastic, Tom. You've got the poll results open here as well. Can you see those ones?
Yes, yes. So the answer for the poll results. So these are two questions that I thought was critical because of the current climate that we're in. And my first question with the coronavirus, the first question is, would you be happy for samples of bowel tissue to be taken over an extended period of time as part of routine care procedures with current NHS precautions? I think 86% answered yes, 10% answered maybe, and 4% answered no. Then I asked, would you be happy for samples of bowel tissue to be taken over an extended period of time in the current pandemic conditions? 49% yes, 49% of patients said yes, 30% said maybe, and 21% of patients said no. And the third question was, would you be happy to complete weekly questionnaires about quality of life and disease activity using an e-form on a mobile device to assess response to therapy, given that the forms would take less than 5 minutes to fill out? And it's an overwhelmingly positive answer of 93% of patients saying yes. And I think definitely modalities like Truecolours are what we're going towards more in managing chronic disease in the outpatient setting. For IBD and other chronic conditions. Thank you for that to everyone for listening to my project and providing valuable feedback and very interesting questions as well. Certainly a lot of work to be done in this field.